All right, we are recording. All right, once you filled out your KWL, go ahead and join the Menti. You can scan the QR or you can go to menti.com and enter that code. So our objectives today are to cover musculoskeletal that we didn't get a chance to cover last week. I think I overestimated. I'm a time optimist. Anybody relate to that? Thinking that I might have this much work, but I can do it in this much time. So I tend to be a time optimist, which is why my lectures usually go a little bit long, but I really try to keep it in the time that we're here in class. So we're going to go over musculoskeletal. If we have time, we're going to go over infection. If not, I built some time in for next week. We'll go over infection next week. Today, since musculoskeletal is a lot of content, I've broken it up into kind of two mentees. So we'll do one, take a quick break. We're gonna do a case study, similar to the one I had you guys practice at home for your assignment this week. And then we're gonna do another mentee about musculoskeletal. So any questions about today? Not so much? All right, let's dive in. I think that musculoskeletal is super interesting. Give me a nice little thumbs up once you have entered the Menti. Well, I figure out how to let somebody enter the room. Okay, that's fine. Just join when you can. Anybody know how to find the waiting room in Zoom? All right. What else?
You got a participant didn't show anyone.
That's what I thought, and it says somebody was in there, but then they don't show up anymore. Yeah, it said Muna was in the waiting room. Okay, well, maybe she left. All right. Oh, good. We got quite a few people that are in the Menti. All right. So let's talk about Welcome, hey, you're fine, just grab a KWL in the back, we're just getting started. Maybe we need new batteries for this guy. All right, old school. Okay, so for the learning outcomes for this first part of the musculoskeletal, we're gonna talk about complications, signs and symptoms, how to know if somebody's had a fracture, which what is a fracture?
Break in the bone.
Yeah, it's some sort of break in the bone. We'll go over different types, but essentially we have 250 bones in our body, and if any one of them is broken, it's a fracture. Assisting and planning nursing care for a patient that has something to help treat that fracture. Describing and preventing osteomyelitis. What is osteomyelitis? Yeah, an infection in the bone. So if we talk about word building, and I really like how your books do word building, osteo, where are we at here? Osteo, anytime you have that prefix or it's on a suffix, that's bone. So osteo is always going to be bone. And then itis, that's always going to be inflammation or infection. So if you're not sure what something means, if you can start putting together some of these pieces of the words, you're really going to be able to figure out a lot about what it means just from knowing those prefixes and suffixes. So we're going to talk about osteoporosis as well, which what is osteoporosis? Yeah, right. So if we're looking doing that word building, osteo means bone and porosis, it kind of sounds like porous, right? Like holes in it. It's where we have those bones that break down and have little holes in it. And then we're also going to talk about pathophysiology treatment for gout. What is gout? Yeah, it's an inflammation of the joints. It's actually autoimmune disease. It's pretty, actually, I take that back. RA is autoimmune disease. Gout is inflammation caused by, we'll go into all those factors. Uric acid. Look at you guys, uric acid. All right.
I think that's hereditary.
It can be hereditary. Yeah. So we talk about our concepts. We're going to cover comfort, mobility. What kind of teaching and learning do these patients need to have? So some things we need to know about some bone and soft tissue disorders. We talk about soft tissue. That's our muscles, ligaments. Sometimes they'll include cartilage in that. Sprain and strain. What's the difference between those?
One is involved in muscle and strain is tendon, strain is
Muscle and tendon. Yeah.
and sprain
Is ligaments. Yeah. So that somebody said that last week, and I thought it was really nice. The strain with the T, that has to do with your tendons, right? So that's how you can kind of differentiate the sprain from the strain. So sometimes that helps to give like a little bit of what's it called? Association. Thank you. You can also have dislocations. A lot of times people talk about what usually we'll see are shoulder dislocations. I was on a youth camping trip one time and this kid was doing something and his shoulder dislocated. He was a football player, so he already had a bunch of injuries to his shoulder. And so it was in Leavenworth, which is, not super close. And so this kid was 14 years old and I had to take him to the emergency room. We had to work, on getting his shoulder back in place. And when we talk about being an advocate for our patients, every time a healthcare provider went into the room, this kid was like 6'4", he was like a linebacker, he looked like a man. And so everybody treated him like an adult. But I knew he was 14. He was a baby, right? And so they would be like, okay, well, we're gonna do this. I say, hold on. Let's make sure we have permission from his parents, that he knows what's going on, that I was able to be an advocate for him. And eventually, super interesting, they didn't actually manually put it back in. They laid him down prone, and then they had that affected arm, they put weights on it. And eventually that weight from the position pulled that shoulder joint back into place, which was super interesting to watch. Anyway, don't do that at home. Please seek care as needed. But it was really interesting. A lot of rotator cuff injuries. A lot of athletes can have these because if you think about all of the extreme motion and mobilities, think about pitchers, football players hitting a lot of movement with their arms. There's also oh, what's it called? Kind of acute injuries, like maybe your shoulder gets pulled back suddenly with something and you can get an injury in your shoulder. Shoulders are really painful. We're going to talk about different types of joint surgeries later. Most common types of major joint surgeries are going to be your shoulders, your hips, and your knees. As we get older, those are the joints that usually will give out and they really cause a lot of immobility. Shoulders, surprisingly, are the most painful. I worked in ortho for a long time, and then I work now as recovery pre and post-op. And 90% of the times, the shoulder patients are the ones that have the most pain. I think it's because you're always moving your arms or this area. Even if you're laying down, you're still breathing, right? You're still moving your rib cage. It's still moving your shoulder around. It's just a really painful area to have an injury. So when we have somebody that has a muscular or a skeletal injury, we talk about RICE. You guys heard this before? So we rest it. So let's say we'll use our foot. We rest it. We're not going to try to walk a lot on it. Ice. How long do we do ice for?
20 minutes on, 20 minutes off.
About 20 minutes on every hour or so. Compression. So like an ACE wrap, we might want to wrap it up and then elevate. How high do we elevate? Above the level of the heart. So if we're talking about our foot, I'm going to lay down and I'm not flexible to just throw my leg up, but I would want it to be above the level of the heart so that that could drain, that extra fluid could drain down. If I'm talking about my hand, maybe I sprain my wrist or something, I could just raise it up here like this. All right, so first question of the day. Left ankle pain, they're diagnosed with a sprain. They ask, how long am I supposed to ice it? What do we say? And if you're just joining on the Zoom, the instructions to join the Menti are at the top of the page. All right, I think that one was too easy because we just talked about how long. But way to start off the day really well. Good job. Congratulations. So let's say another question. The nurse educates the nursing assistant to use which of these for patients to provide safe movement. So these are what some of those questions that are kind of confusing. So when you're looking at these type of questions, you're like, what am I doing? I'm educating a nursing assistant, but safe movement. So it's saying if you're giving instructions to somebody, what type of assistive devices do you use? Then, okay, what do they mean by this? So you can read through and see, okay, we're talking about what are we using when we're moving patients around. So non-skid footwear, that's probably a pretty good one, right? We don't want people to slip through. Lift patients under the arms, reposition, I'm not so sure. Sit at bedside before standing. I like that one. Why is that important?
Orthopedic hypertension.
Orthostatic
Yeah.
hypotension, right? And some people, you know, it takes them just a minute to get their bearings, you know? I just want to give them a moment for that. Use a lifting device, 100%. Like, just know, you guys, I want you to have long and healthy careers. And if you never use a lifting device, chances are you're probably going to have back injury, shoulder injury, something where you're going to be sore and hurting. Anybody here worked in healthcare for a while? Anybody already have some injuries from that? Yeah. So I know it seems a lot of trouble sometimes to get the assisted device that you need, to get another person to help you. But please remember that, you know, your patient might need care, but your patient's going to need care in 10 years from now. And if you're injured and can't do those things, it's much better just to get another person, go get that device that you need so that you are not injured, so that you have a healthy career. Lifting sheet. What is a lift sheet? Like a draw sheet. Yeah. Anybody here not worked with a lift sheet before? Is okay if you say you have it. Yeah. So really, a lot of times you just get a flat sheet and you might fold it in half and you put it under the person and you want to get most of their bulk underneath them. So usually from about shoulders to hips, it goes underneath them. And then, like, if this is the bed, we're like, all right, you get that side, I get this side. On the count of 3, we're gonna get our legs, our hips nice and underneath us, right? Back in good alignment. We're gonna 1, 2, 3. We're gonna go up. And that helps us not to have to grab their arms or legs, and it gives kind of a smooth movement to them, especially when we talk about skin and patients with that really frail, fragile skin that could tear. That kind of protects your patients as well. Oh, hey, Brad.
I'm expecting, a guest come over, and they had cancer. And cause I got them some food and coffee. So I don't want this to go to waste. Would anybody, I'm so sorry. Would anybody would like to have this later today? I've just written through. Okay, I do apologize.
Yeah, that's okay. Thank you.
Okay.
Yeah. All right, so somebody has McDonald's in the fridge later. All right, walking belt. What's a walking belt? What do we call it sometimes, usually in the Northwest? A gait belt, yeah. Different parts of the country are gonna call things different. They might call it a little bit differently, but a gait belt. I love gait belts. They're a pain in the patootie, but they're really helpful because sometimes when patients are a little bit wobbly, you have something very solid to hang on to that it goes right around the middle of them. And so you can really direct where they go. Gait belts have helped so many people not fall when they're really wanting to. All right, carpal tunnel syndrome. This is an issue when anybody ever had carpal tunnel syndrome? Yeah, you might not make it through nursing school without getting a little bit of carpal tunnel issues because of all the typing and all the movements that we're doing. It's an inflammation of that area that presses in on the nerve that runs through and usually causes numbness and tingling. Patients usually will report it more at night, necessarily at night, but they'll wake up with their hands asleep. If they raise their hands more, like a lot of times I'll say while they're driving, their hands will fall asleep. It's usually numbness, but with some pain as well. It really can impair what you do because you think about if your fingers are numb.
Recording in progress.
Thank you. If our fingers are numb, then we can't feel what we need to do. So think about us as we're doing our nursing labs, right? You're going to be learning how to insert a Foley catheter. Are we going to know how to do that well? Are we going to be able to do that well if we can't feel what we're holding or what we're doing? That's going to be really challenging. So what do we do to help patients with this? A lot of times we want to avoid the activity that caused it. So a lot of those repetitive movements, we can't always stop all of those. So sometimes we have some assisted type things where we, have you seen on the computer keyboard, the keyboards that are kind of arranged a little bit different, shaped differently, or they have the bump on the bottom to keep your wrist in a better alignment. Sometimes that can help. Sometimes we'll splint it just to hold the hand in a proper position that will help keep pressure from that area. Anti-inflammatories. What's a common over-the-counter anti-inflammatory?
Advil.
Advil or ibuprofen. Yeah. So with Advil or ibuprofen, really great to be used. It can help with all kinds of inflammation. What are some negative effects that ibuprofen can have?
Your kidneys. I'm sorry.
Your kidneys, what is that? Stomach issues. Yeah. A lot of times stomach issues, because how much ibuprofen should we take or Advil? What's the recommended dose? Anybody know?
No more than 800.
Yeah, you don't want to take over 800, and technically 800 is usually a prescription dose. And that's what's really interesting when we talk about medications. There's over-the-counter medications that we can take at this dose, but if you increase it up to a certain amount, that then becomes not over-the-counter where we can just kind of take it as we feel like it. That becomes a prescription level dose. So yes, sometimes we'll see it at 800. If you're in the military, that's like the most common prescription I feel like they give. But you don't want to take that over usually every like 8 hours. Well, yeah, more likely you'll have something like 200 to 400 to 600 every 6 to 8 hours. I always say follow the bottle directions for patients, but you can have a lot of GI issues because it's very harsh on the stomach. And so what do we tell people when they're taking ibuprofen or anti-inflammatories? Take something, eat some food with it, drink a glass of water as well. That helps to kind of be a little buffer on the stomach and helps to decrease the inflammation. A lot of people can get like ulcers from taking chronic anti-inflammatories. The other thing that can be associated with anti-inflammatories are bleeding. So if you think about aspirin, aspirin is an anti-inflammatory. We give that all the time for patients, right? Like a 81 milligram aspirin is a heart healthy dose. That's just kind of to give a little bit of blood thinning just to help prevent blood clots. But that's a blood thinner. So is ibuprofen. It's a mild blood thinner. But you can see how if people are taking these mild blood thinners, maybe at bigger doses than they should, for a very long time, that can actually make them a higher risk of bleeding. So it's good to know, like, even though we might tell patients, hey, you want to take some anti-inflammatories, we want to give some caution or some education to them as well, so they know what to look for and what to watch for. Surgery is the usually last step, and that's where they'll go in and surgically. Actually, I had both of mine done, and I can't even tell where the incisions are. I had a great surgeon, but they just open up the wrist and they just make a little incision to relieve where that pressure builds up. It was a really short recovery. And then I had hand therapy, which really felt just like I went to this occupational therapist who massaged my hands for a half hour. It was like the best thing of my life. You really want to teach prevention. And so not doing those repetitive movements over and over without taking a break, having good alignment, things like that, prevent as much as we can. All right, so fractures. We already talked about fractures. We know there are breaks in the bone. They're usually caused, so there's two causes. Usually trauma, which is what we kind of associate them with usually, right? Like, this is horrible. Like, all I can think of is getting hit with a baseball bat, but maybe you're a baseball player and you slide into the base and you get hit and then you break your leg. Maybe that's better, I don't know. Or pathological, and what that means, it's from a disease process. We'll talk more about that later. I think a lot about osteoporosis, where the bone is really porous and kind of thin. It's more prone to break because it doesn't have the structure to maintain the bone. So closed fracture versus open fracture. This is really important to know because it helps us know the extent of the fracture and also the treatment. So a closed fracture is when you have your bone and it's broken, but the skin is all intact. Open means that that bone broke and popped out through the skin. So those are always going to be more gnarly, a lot more treatment involved, and a little bit more emergent as well. With the broken, big risk of infection, right? If it's closed, we still have our normal body systems in place that help prevent infection from getting inside. When it's opened up, all bets are kind of off, especially depending on how they got the fracture. So here's different types. It'd be good to know about some of these. So longitudinal down here, big long break down the middle of a bone. Oblique through the middle, stress fracture. You look at these with ladies, especially wearing high heels, right? Because you can see how if you're up higher and you're always putting pressure on that bone, put a little stress fracture on there. Spiral fracture, it's that twisting. That's one that usually we see in
Wood chipper accident?
what's that?
I can think of wood chipper accident.
Well,
Your arm
it's
got
usually an abuse, right? Because grabbing somebody's arm and twisting and pulling, that's usually where we see that. So, if you work in pediatrics and you have somebody that comes in with that type of fracture, we want to do some screenings to make sure, because it doesn't mean that it happened from abuse, but it is one of those things that kind of says, hey, I want to make sure that this person is safe. And so we want to evaluate for that. Anyway, I'm not going to go through all of these, but just know, kind of look through and be semi-familiar with the different types of fractures. So when we talk about signs and symptoms, how do we know if somebody has a fracture? What are they going to do? Well, they're going to be in pain. They're not going to be able to have that same range of motion. I broke my arm when I was 8, I think, and I told my mom, and she was like, my mom was a nurse, so that's kind of what it is. It's like, you're really fine. You don't need to go to the doctor. And still, I was like, the next thing was like, Mom, it really hurts. And she was like, oh my goodness. And so I think it was a couple days later, she finally took me in when I wasn't using it. And it was broken, and she felt really bad. And I felt really cool with my blue cast that I got to wear. You might see some limb rotation. A lot of times, think about your leg, right? So if you fracture, I think especially our femur, when you lay down, your legs kind of do like this, right? If you fracture your femur, that's going to interrupt a lot of that structure of your leg, and it's probably going to tilt out abnormally. So that's what they mean by the limb rotation. It's not gonna be hanging or looking like it normally would. So compare, especially if it's on a limb, a leg, an arm, compare that arm to the other arm or leg and see, does it look normal? Deformity or shortening of the limb. That's also really common in the femur. If you think about, I've got a big long femur through here, and if it breaks, especially if it completely breaks, and then it kind of, these muscles are actually gonna pull those broken bone parts together. I can't even imagine how painful that must be. Like, it just has to be horrible. But you might see some shortening. Also, bruising and swelling, super common, right? There's gonna be blood and other things under the skin trying to help actually, your body's trying to splint it. So when they have that swelling and things that come around it, your body's actually trying to hold those bones in place. That's part of why we have all the swelling around there. So diagnostic tests. When we say diagnostic test, it almost always means like an X-ray, CT scan, something like that. So we're gonna do something with an X-ray image to look and see. That gives us a pretty definitive diagnosis to know if something is broken. Emergency treatment. So when we say splint it as it lies, splinting is important. Let's say we break our arm. Splinting just helps to give extra support. Our bones are what gives us support. Like, everybody just raise your arms up, right? Raise them up. Look at all that. Now, what would happen if you tried to raise your arms up, but you didn't have bones? It would just be like, I think about, those, the big, air-filled guy that like this, like, we wouldn't have, like, our muscles would probably do something, but there wouldn't be the structure that's there. So we need to give our bodies structure to help hold those bones in place and prevent some pain and injury. So if it's our arm, you can just get a stick. If you don't have like an actual splint, you can get a splint from the hospital or somewhere else, and you're just gonna put that there, and you're just going to secure it away from where it's broken necessarily. You don't want to, if my arm, it really hurts right here, I'm not going to be wrapping things around it right here. I'm going to put that splint underneath, and I'm going to probably wrap it here and here just to help give some structure there. And then you want to seek medical treatment. When we say splint it as it lies, you can tell, wow, my arm is like, there's a like a elbow shape there, but it wasn't there before. Don't try to realign it. We just want to splint it as it lies, which means, okay, I'm just going to get something underneath and I'm going to secure it just how it is here, because I don't want to cause any more damage than what's already happening. And then get treatment. So our therapeutic goals when somebody has a fracture is try to realign those bone ends. Our bones are so amazing. They're incredible. You can realign them up, they will grow back together. And that spot that grows back together is actually stronger than the rest of that bone area because it really doesn't want to be broken again. And we want to immobilize them to allow it to grow back together. Okay. Cue recognition. You find a patient on the floor. The effective leg is a little bit shorter than the other one, and they have 8 out of 10 pain. What do you do? So turn to your partner, tell them, what would you do?
Yeah, and like we're
All right, let's see what F.A. Davis says. It says, splint the leg as it lies and call for help. I think I kind of, when I read this, I thought, I would probably call for help first. Meaning, I don't know if I'd leave the patient, but I sure would go to that door and be like, help, and then go help and get the patient, right? But if you don't have anybody close by, splint that leg and then go get some help. And that's because we don't want to cause any more damage. And they said splint it with a towel or bed sheet, just something to help kind of keep it together. So here's the healing process. I like this picture. I really like your guys' book. We just changed to this publisher. It's a different book than we've been using. I really like all the pictures. I think I'm a really visual person, but I like how it shows us this piece. Like, well, maybe you have an incomplete fracture. That means complete versus incomplete means incomplete, it did not break all the way through the bone. If it was a complete fracture, it would be all the way through. And then it shows here, look, these little osteoblasts and fibroblasts, I like how they're purple. They come together and then they start forming, you know, the callus. And then, you know, this new bone, and a lot of times it even protrudes up because it's giving extra reinforcement to that area. And that's how it actually gets stronger. Because if you have a break in a bone, you typically will not break right at the same spot. If you break it again, you're going to break somewhere else because your body is like, not again, not in this spot. Might be somewhere else, but it's usually not in that spot. So management, so closed reduction. So when we talk about the open fracture, right, where it's broken through the skin, so it's kind of the same thing with open and closed. How we fix it, closed reduction means we keep the skin closed. We don't do anything to open up that skin. So manual realignment, it might just be, hey, I'm gonna turn this bone, and this is not anything we as nurses will do. This is the providers. So we assist, we help. Thank God we don't have to do this, because I don't know, there's something about bones. I'm not super happy with wanting to do it myself. But you know, they will realign it. They might do elastic wraps or splints based on the severity. If it's a small fracture, you might not need to do like a full cast. If it's a pretty severe fracture, they might do a cast. Has anybody else had a cast in here? Ever? Yeah. So a cast is a hard outer layer. So we think about how we were talking about splinting the bone. It completely wraps it because it's like, hey, this bone really needs to heal. We really want to protect it and keep it in the right position. And usually they stay on for about 6 weeks or so. We might also do something that's called traction. So, you know, I talked about having maybe a femur fracture, especially when those bones have pulled apart and you have that shortening of the leg. That causes incredible pain because you can imagine those bone fragments are very sharp. And now they're digging into the muscle around there. So what we do is, traction means, gosh, I'm so visual. Let's say this is a bed. Yeah, they pull it. They pull it. So let's say this is a bed and this is somebody's foot. I'm not going to pull this. This is somebody's leg. And we just get things that gently pull that leg so it helps to realign those muscles. It pulls it gently down so that the bones aren't kind of poking in at some of the other muscles in the leg. We do that either by putting a harness on the leg, on the foot, and then there's weight that's at the end of the bed. I usually don't do this very often. I used to see this a lot more about 15, 20 years ago. Usually now, as soon as somebody has a fracture like this, we just rush them right into the operating room because there's such a huge risk of injury and other things going on. But especially when you're in a remote community, you're waiting for either a surgeon to get there or to send the patient somewhere else. You might have to give some traction to help realign that spot. So yeah, go ahead.
Does that include like when they put pins in and stuff like that?
Oh, we're gonna talk about that. Great segue. So open reduction. So that's kind of like we said, open versus closed. Open means they actually need to go in and do surgery and cut an incision and fix those things together. So there's two types. There can be internal fixation or external fixation. Internal fixation means, hey, I broke my arm. It's all a mess in there. They had to go in, put some plates and screws and kind of build that bone back together. And then they closed it back up. External fixations is when you have a metal frame that's outside of your body and holds it together. I think, so this is internal fixation. So you can see there's a big plate, screw, some screws here. This person had a pretty gnarly hip fracture where they were just putting all this together. This looks like ulnar fracture, I think, here of the arm. So it would be, I believe, like this. And so they put like pins through here. That's internal fixation. External fixation might look something like this, where you have bones, or you have the screws and pins and plates inside your leg, but usually it means you really messed up your leg or whatever bone that is, and you need external fixation to kind of help hold this back together. And eventually it comes off. My husband had one of these. I'm from Kansas. He's from out here. He went to this tiny little college town and he showed up with this monster external fixator that he had. He was supposed to be there to play basketball, so he didn't play that first quarter. And it was kind of interesting because, you know, when you're a freshman, you don't necessarily follow your mom's advice or do the things you should. He didn't see an orthopedic doctor right away. And so all of those pins and screws that he had here, his skin started growing over it. So by the time he went to go see a doctor, they were like, I didn't put these in. I don't like dope. And so they wouldn't do anything. So my husband, and this is a long time ago, he called his orthopedic surgeon who was here in Washington. And so the surgeon was like, listen, you got to get that out of you. It is time. It's overtime. And so he told him to go down to the college shop and get the right size wrench. And my husband just like took those screws off by himself, which I would have been like, you did what? Did you clean? Like, this is before I knew him. Thank goodness. But anyway, so you can see how you really need to make sure they have good follow-up care, because it's open, right? There are things going directly into the bone. We really don't want to cause infection with those. We want to make sure there's good care happening. And there's a lot of good monitoring because these are usually a lot more extensive fractures. We really want to make sure that we're looking and assessing them. Have you guys gone over like circulatory or neuro assessments and foundations? Neuro assessments? Yeah. So if you're assessing somebody that has an external fixator like this, what kind of things are you assessing? Pain? Circulation, what was that? Numbness? Oh, redness. Yeah. Oh, yeah. Especially around the sites where it goes in. Vital signs. If it's numb. Yeah, visually, I just want to compare it to the non-affected leg. I'd really want to compare the pulses, right? I always want to get my pulses, my pedal pulses in check, but I want to check this compared to this over here. Yeah.
So why would they do that instead of internal fixation?
Because internal fixation means that the bone has enough structure left that you can throw a few pins on and it will stay in shape. If you really destroy your bone,
Like little shards?
I mean, not little shards, but lots of pieces.
Mm-hmm.
Sometimes then they're like, okay, even if they put a bunch of metal on it, it's not necessarily going to stay in a good space, or it might be incredibly painful.
Okay.
So they have to put those external pieces on.
Okay.
Yeah. Yeah, it's usually related to the extent of the fracture.
And it also depends on how small the area is, right? Because my son broke his elbow, like he broke his elbow and he had to have pins, but they said there wasn't enough, like, to hold him.
Right, yeah. You want to make sure where it's at, you know, you have enough bone around it, and if it's right at a joint, that might be a little more difficult. Yeah, well, that's hard when babies have the fractures. Okay, the nurse is caring for a patient with an external fixation. So just like that picture we just saw, which of the following actions does the nurse implement? Before you answer, let's just do some test taking practice. What is this question asking us? Do we want to choose the things that are correct, like nursing appropriate or nursing inappropriate?
Appropriate.
The correct things, right? We want to say, yes, what are the things we want to do? Always really good to make sure we understand that, because different questions ask you, they might want you to identify the incorrect things. So we are identifying the correct things. So select all that apply. What do we want to implement? All right, so we got some good answers here. I like the variety. Oh, hold up. There we go. Okay, so you can't really avoid touching the pins, because if you think about the pins that are sticking out, they're going to be there. We can't really avoid touching them. That's not something we necessarily would do. We do want to follow our agency's policy for pin care. Just a little help with questions. Anytime it says follow your agent's policy, that's almost always a correct answer, because we want you to follow whatever policy is in the place that you work for. Different places are going to have different policies. make sure you follow your policy. Cleansing with hydrogen peroxide is not usually recommended. Usually they'll have some sort of cleanser, soap and water, something like that that'll have you clean with. Loosen screws holding the pins during cleaning. We don't ever want to loosen those screws. That is a provider privilege. Like they are the ones that are going to be doing that. Monitor the pin sites at least daily. Absolutely. Because we really want to look at the color. Is there any exudate or something draining from around there? And then we want to use aseptic technique for pin care. What's aseptic technique? Clean. And have you guys learned aseptic versus sterile and foundations? Yeah. So when they put in the pins for these external fixators, they do it in surgery using sterile technique. They really want to make sure there is no infection in there. When they're done though, you have these pins sticking out of the body. Just by way of what they're sticking in through your skin, we can't keep it sterile, anytime after it leaves the operating room. So we're going to use aseptic technique. Bum, bum, bum. Okay, so some complications. So when patients have fractures, what are things we need to be aware of and look out for? So hemorrhage, what is hemorrhage? Bleeding, yes, that's been bleeding. When we're looking at somebody that has excessive bleeding, let's say they fall and break their hip. Where are we monitoring for the hemorrhage?
I wouldn't say stomach pelvic region.
Stomach, pelvic. I'm gonna say a little bit different. How are they positioned? Somebody broke their hip. Are they gonna be walking around
No, they're outside.
on their side, on their back
Mhm.
usually? So if somebody is bleeding, they're laying down flat. They broke my hip. Where is all that blood gonna drain
To
to?
the back.
Usually back here. So it's usually where you're gonna see the blood or a hemorrhage kind of go to for a pelvic injury. So think same thing wherever the fracture is at. The bleeding is going to be somewhere around that area, but it's going to follow gravity, a lot of it. So you don't always look right at that, not incision, but not like right at the fracture site. Look to see how they're laying, how they're sitting, standing, wherever that's at, and then look to see where gravity is going, because that's where the blood is going to eventually flow to. Acute compartment syndrome. Okay, so here, this shows different compartments of our legs. This is a normal leg compartment. So if they sliced your leg clean off and you just looked at it, this is what it would look like. And you can see where you have your bones, your muscles, there's blood flow that goes through here. They don't show the nerves, but those are all in here. When you have a lot of swelling or bleeding around a site, it really pushes in on the muscles, the nerves, the blood vessels. So what's going to happen to all of those? What's going to happen to the blood vessels?
They're gonna get smaller.
They're going to
clamped
get
up.
pushed in, all right?
Yeah.
So if I have blood that's pumping from up here, trying to get down to the foot, what might this foot look like if that blood flow is cut off?
Cyanotic, it's gonna look purple.
Yeah, it might look purple extreme. Usually some blood flow is able to get through, but not very much. Usually it might look pale, depending on their color. Like I would compare it to the other leg, right? Always have to compare the abnormal to what their normal is. If they have a broken foot, compare that to the normal. What about pulses?
Gonna be diminished.
Diminished or none, which is again, why I always say, compare it to the normal foot, right? Because you might say, okay, I can feel it. And then if you feel the other foot and you're like, oh, holy moly, there's a big difference here. That's going to be an indicator. What about the pressure that it's giving on the nerves? What is a patient going to experience with pressure on the nerves?
Pain.
A lot of pain. I would say sometimes numbness, tingling. So when somebody has a fracture, we always want to evaluate for compartment syndrome because it actually is a medical emergency. Those patients have to be rushed into surgery and they usually will make an incision straight down and open up that area to release that pressure. So we always are monitoring. It's usually a limb. When I say limb, that means your arms and legs. We're always monitoring somebody with fractures, their pulses, their sensation. Cap refill. What's cap refill?
how fast they're.
Yeah, usually you do on your fingertip and look at your nail bed, pinch it, release. How long should it take for color to come back? About 3 seconds usually. Longer than that, they're not getting enough flow. What happens if they have nail polish on? Do you guys know what to do?
Look at the pad of the finger.
Yeah, just look at the pad. You just squish the pad of their finger or their arm, wherever you can get to. You just push down, like do it on yourselves right now. Just look at your arm, push down, let up. You should see blood flow kind of being able to swish out and then come back. All right, so let's go back. Some other issues, neurovascular compromise. That's a really big word. What's neurovascular? It's just the flow of blood and path of nerves. So when we look at the compartment syndrome, it just means that your blood flow and nerve conduction is going to be compromised or interrupted somehow. You might have infection. What's non-union? Yeah, so when we realign the bones, we want it to heal back together. There's a possibility they might not do that. And if somebody's bones are not healing and aligning and growing back together, that's called non-union. There might be thrombolytic complications. Okay, let's break down this word. What's throm? No? Anybody? Usually talking about blood and then embolic.
Clots.
Usually it's causing some sort of occlusion, right? It's like causing disruption of something. So it's usually a blood clot. So when somebody, they break their leg, maybe they don't have great blood flow, they're not up walking around a lot, they might end up getting a blood clot. Why are blood clots really dangerous? Where can they travel to?
Heart and brain.
Yeah. If you have a clot in your legs, usually they'll end up, they travel, they're gonna go north or up. They're gonna get into your vena cava, and they're gonna either go to your lungs, your heart, or to your brain. And that means lungs, what happens, what is that called if the clot goes to your lung?
Pulmonary embolism.
A pulmonary emboli. If it goes to your heart, what does that cause?
A heart attack.
A heart attack, an MI, myocardial infarction. What about your brain?
Stroke.
Yeah, some sort of an embolotic stroke or a occlusive stroke. It's occluding the veins. Fat embolism syndrome. Anybody want to take a stab or remember what this is?
Yeah,
White, the yellow,
Sorry.
sorry, the yellow part of the bone, that it's really.
The marrow.
Right, so usually it's in your long bones that are producing the marrow. So long bones, think legs and arms. When they're broken, some of the marrow can get released into our blood, and that acts kind of like an emboli, where it can go and get dislodged and go into our heart, lungs, brain and cause like an emboli syndrome.
I had a question. So, the ICU I worked on, there was a
Yeah.
patient, she has a broken left leg
Mm-hmm.
and she had a bag part. And so she had a stroke. And they were saying, they were asking like, oh, there they go. We think, they think it might have been fat emboli
Mhm.
that did it.
Yeah.
And I asked the surgeon, I said, how do you know the difference? How would you know if it was a normal blood clot or a fat? And he was like, we don't, there's no way to tell.
Yeah.
Is that true? Like so what's the point of,
Huh.
that there's no way to tell or suss that out?
Well, it's not about being able to tell like when somebody has it, knowing which one they had,
Yeah.
because essentially they're gonna have the same symptoms. But depending on that patient, their risk factors are gonna be really different. We know that if somebody has a long bone fracture, especially a pretty bad one, they're at much higher risk of having a fat embolus. So we're gonna be watching for that, monitoring for that. Whereas somebody else, you said it was a stroke?
Yeah.
Okay, so it went to the brain.
Yeah.
So, somebody else who maybe has some blood clotting issues, who has some other risks of having, a stroke for other reasons, we'd want to monitor. Usually it's the risk factors. If somebody's old, really sick, and then gets hit by a car like that, who knows what it's gonna be. But if it's somebody who's kind of younger that doesn't have those same risk factors, most likely it's a fat emboli. Oh gosh, yeah. So unless she had some crazy back history, it was a fat emboli, because we know that's something that it's a complication that can happen. And to know what caused it, the only benefit I could see would be prevention in the future, right? Because if it's a fat emboli, there's really nothing we can do to prevent that from reoccurring. But if it happened from some other reason, then we might do some things, they might be on some medications to help with that. But I think it's really likely, it would be very unlikely that person would have the emboli from anything other than a fat emboli from the bone. You wouldn't, it'd just be prevention.
Oh. Yeah, that's what I asked too, and they said because of her injuries, like, because they found the stroke, like, they realized it in time, the nurse noticed it came to her really quickly.
Yeah,
But
yeah.
they said because of her injuries, they couldn't give her the TPA because it was contraindicated because the risk of bleeding, that benefits of bleeding from administering it outweighed the benefit of saving her from the stroke, so they just let her have the stroke.
Which seems crazy, but our brains are amazing. So we're going to talk about brains. Oh gosh, it's med surg 3. But there's something called neuroplasticity, where we can have damage to our brains. People can have strokes where they cannot talk, they cannot walk, they are really impaired. But neuroplasticity, so break that down: neuro, nerves, and plasticity, kind of plastic, bendable, molding. Yeah, our brains can find new pathways and build new pathways, so those patients can actually learn how to walk, how to talk, how to do all those things. Not every patient is able to fully recover from a stroke, but a lot of patients with strokes are able to regain some function afterwards. So I can see where somebody who's very young and healthy, they don't want to increase her risk of bleeding more because of her injuries, and might say, okay, it's better for her just to have this stroke, and then we're going to rehab her afterwards. Not every stroke makes somebody totally incapacitated. It kind of depends on the extent of the brain part that it affects. All right, I'm going to move us on because it's super interesting, but I want to be respectful of your time. Bum, bum, bum. Okay. This is one of those priority questions that we're working on. So if they have a left tibia fracture, which following is a priority? So knowing what kind of things people are at risk for, what's a priority finding? All right, nice job. Absent left pedal pulse is correct. What could that be an indicator of? Compartment syndrome. Yeah, yeah. And it could be decreased circulation, but especially if we're looking for like a tibial fracture, we want to make sure there's no compartment syndrome there. So nursing diagnoses, these are different than medical diagnoses. We're going to say, okay, is that acute pain, impaired physical mobility, risk for peripheral neurovascular dysfunction? So what do we do for that patient who's had a fracture? We've talked about neurovascular checks. I want to do pain management. We're going to get more into pain management in a couple weeks. We talked about cast, traction, pin care, palming a wet cast. There was a picture of this in your books, but just when the cast hasn't totally hardened, you don't want to just grab it. You kind of want to slide your hands underneath and kind of make kind of a big flat surface and kind of gently raise up and move around until that cast has totally hardened. Skincare, want to make sure the skin around wherever the fracture is at, if it's that open, has the traction, we're looking at where the pins go in. If it's just around the site, maybe they have a cast or a splint, we're looking at that skin monitoring for breakdown. We really want to monitor these patients' nutrition because they're going to have an increased need of higher protein, calcium, other nutrients that they need to heal that bone. There might be some self-care deficits, meaning if they can't, they break their right arm, they might not be able to brush their teeth as well or do other things that need to help them with that. And then psychosocial as well. Oh, here's a picture of palming a cast. Just a way of picking it up without smooshing in the cast material. Bivalving the cast, this is just taking it when they end up removing the cast. Sometimes they'll open it up for a little bit of release. I'm not gonna go too much into that. It's just interesting. Education, we're gonna talk to them about cast care, not getting it wet, looking at the skin and toes, not sticking things down into the cast, which people are not great at listening to because it itches. Pin care, nutrition. And okay, the nurse is collecting data on a resident who has fallen. Which data would alert the nurse to a possible hip fracture? Select all that apply. So the patient fell, we're worried about a hip fracture. What things might indicate a hip fracture? Oh, I just realized that the one answer was the question. I guess that's an easy one to rule out. All right, so yes, deformity looks weird. Groin pain, for sure, they're gonna have that with a hip fracture. Increased range of motion,
No.
that's gonna be decreased range of motion. Limb rotation, absolutely, if it's a hip fracture, that leg is probably gonna be kind of falling off to the side a little bit differently. And then are they gonna have lengthening of the limb? Shortening of the limb. All right, good job. Osteomyelitis, that's the infection of the bone like we talked about. Might start with a little bit here, you might see it kind of pouch out and eventually pass a week out.
I have a question about that.
Yeah.
For osteomyelitis, does it have to, can it happen without it being an open fracture or cut, like it just happened and everything?
Yep. Yep, sometimes it's just you have an opportunistic little bacteria or bug that gets in your bloodstream and finds a home. Not very often, but it can. Usually there's pain where it's at. There might be some redness localized above where that bone is at. You might have swelling, might have a systemic fever. And by systemic, I just mean like that's a systemic response. You might have a fever in your body because your body's trying to heat up and kill whatever is invading there. So curative therapy, how do we make it totally go away? We're gonna give some antibiotics. They might do a debridement, which means they go into that bone and they cut in and they clean it all out and then patch it back up. That's a debridement. Reconstruction is part of that. Palliative care therapy. See, that's a lot of times, maybe in diabetics, I think about foot injuries. So a lot of times diabetics, and we'll go more into this when we talk about endocrine, they don't feel sensation the same way we do after time. They can have damage to their nerves. They can also have slow wound healing. There actually was a patient in clinicals a couple weeks ago. He had a pair of ill-fitting shoes and he just kept wearing them. And he noticed after a while, he had a big red like wound on the bottom of his foot and thought, I don't want to give away these shoes. They're nice shoes. We kept wearing them. So what happened?
The sword.
Big sore, big infection. That infection got worse and worse until eventually, saw his doctor, antibiotics, they did a debridement, they cleaned it out. That infection went to the bone. So they had to more antibiotics, more debridement in the bone. Eventually they had to start amputating part of his foot. And so a lot of times when you get infection into the bone, it can be very hard for it to treat. And so a lot of times, like this gentleman actually had a few series of amputations where they first had amputated the first part of his foot. They did antibiotics for quite a long time and other surgeries to try to, salvage as much of his foot as they could. But it was still infected, getting worse. So they had to go in and cut off more of the bone in his foot. So that we kind of talk about that being more palliative, or we're just trying to decrease how much infection is kind of spreading through that bone. And so now this guy is on suppressive medication or antibiotics to try to keep that infection from getting worse. And then amputation if we don't have any response to that. So osteomyelitis, so osteo bone, myelitis, the infection. Prevention is key, right? We really want to keep the bone from getting infected. So if we have something we can do, like caring for patients with an external fixator, you know, we really want to make sure we are cleaning it, we're looking, we're monitoring for signs of infection. If it's somebody who has an open fracture, like the bone is poking through the skin, we're going to be really careful to try to keep that as clean as possible to reduce how much germs or bacteria are exposed in there. Sterile dressing changes if they're ordered, and then medication teaching. When we talk about medication teaching, usually it's about antibiotics. What do we tell people? If we're teaching them about antibiotics, what do we teach them? Yeah, finish it. Use the whole bottle, right?
Feel better.
Yes, yes, that's so huge. I mean, that's how we ended up with MRSA, VRE, some of these super infections, because a lot of times people are like, oh, I feel better now. I'm going to keep the rest of this bottle in case I get sick later. But the way that antibiotics work, they kill off most of the bacteria in the beginning. But you need to finish that treatment because there's a few bacteria usually that still take a little bit longer to kill off. Those bacteria, after they've been exposed for a while to the antibiotic, can become resistant to it. So that's what MRSA is. It's methicillin, which is the antibiotic, resistant Staphylococcus aureus. So it's really hard to treat because we can't use some of the regular antibiotics that we use. We'll talk more about antibiotics throughout your whole program, but just yes, if you ever see a test question that says continue taking your antibiotics for the full time, it's almost always the correct answer. Your patient's right great toe is red, swollen, and painful following surgery. What action do you take? Actually, you know what? We're getting kind of close to the time I wanted to end. What else do we have here? Boo, boo, boo. Okay, I'm skipping over that. Osteoporosis. We talked a little bit about this, and we talked about aging. So this is that porousness to the bones. Usually it's because people don't have enough calcium in their system, and so it's going to leach that calcium from the bone into your system because you need calcium for cardiac function, other muscle function. You need that in your system. Makes you more prone to fractures. You usually see this in people's spine, wrist, and hips. All bones can be affected, but the remodeling process doesn't always happen uniformly, if that makes sense, because they don't have a lot of calcium. We're trying to get it back into them so they can heal back up. It's pretty prevalent. Women are at greater risk than men. Usually it's smaller, white, smaller stature women. Hip and vertebrae fractures. I used to see this a lot when I worked in interventional radiology. Somebody would just take a weird step and their vertebrae would be so porous, all of a sudden that vertebrae would go, and it would cause a lot of pain. In IR or interventional radiology, if it's within a certain amount of time, they actually can go in with a molding into that vertebrae and actually fill it back up. And it causes almost immediate relief of that pressure. But especially if it doesn't happen right away, and depending how the fracture is, they're not always a candidate for that, but it can be really painful. These patients are at higher risk of death, especially that first year after having a hip fracture. Hip fractures have a lot of impact on patients' lives. They're not able to move as much. They don't get up as much because of that. They're at higher risk of dying in that first year after a hip fracture. Osteoporosis, non-modifiable. We talked about aging, gender, history, postmenopausal. Some of the hormonal shifts can make you more at risk. Modifiable risk factors. What can you do to help prevent osteoporosis? So this is really important. If we have somebody come in that they've already been identified as having osteoporosis, we're going to talk about not using too much alcohol. We're going to make sure that they're getting enough calcium and vitamin D. And why do we always want to put vitamin D and calcium together?
It helps absorb it.
Right, right. If you don't have vitamin D in your body, you can't absorb the calcium. So you need that. Excessive caffeine, protein, or sodium can be a barrier. If they're sedentary lifestyle, that's not very good. We want them to be up building muscle mass and increasing their bone strength. And smoking is also a risk factor. Prevention. So in younger people, we want to make sure they've built enough bone mass before 30, getting them a lot of calcium in their system before then, and after. Weight-bearing exercises, and then avoiding alcohol and smoking. So signs and symptoms, back pain, fracture, what's kyphosis?
Come back to, curvature of the
Like a
spine.
little humpback,
Yeah.
right? You
like
might see that
question mark.
sometimes. Let's get through this. How do you diagnose it? X-rays, right? That'd be a pretty common way. You might see some pores in there. They might do some laboratory test, the calcium, to see how much calcium do they have in their system. Also, you're going to notice that phosphorate or phosphorus is usually increased in these patients. We kind of talked about this. So some of the medications, anti-reabsorptive medications. That just means they're medicines that help the body keep from absorbing calcium from the bone. They're saying, hey, we know you have all these bones with this, like they're juicy with calcium, but we don't want you to take it from there. So you might see medicines like Fosamax, that's a pretty common one. Or you have the anabolic or bone forming medication. One thing that's really important for these anti-reabsorptive medications is that they can have a lot of gastric upset. Like they can be harsh, like on your esophagus. So if somebody has reflux or GERD, we really don't want them to lay down right after taking it, because if they kind of flux up a little bit, that can be very damaging to their esophagus. It also, there are some of those medicines that have to be taken all by themselves. So you really want to make sure you don't give any medicine to them before, like 30 minutes usually before or after you take these medications, because you want this medicine to work and you don't want those other medicines not to work. Here, you want these ones don't play nice with others, is what I like to say. Like we just have to separate them out. Let's move on. I think we're about done. Oh, Paget's disease, the last one. Okay. It's a rare, non-curable bone disease. It just causes weakness of the bones. So if you have somebody who has Paget's disease, just know a lot of the symptoms and management are going to be similar to osteoporosis, right? They've got weak bones. We want to give them what they need to grow more bones, but they might have just some fractures that happen. And you just want to help try to prevent them. Bone cancer. So bone or sarcoma cancer. That's the most common that you might see. Usually it's in younger adults and kids. That's where we would see bone cancers more, but you might see it in older adults. Same thing as like a bone infection. You might see swelling, pain, deformity, and you're just kind of looking to see what's the cause. Sometimes they do surgery, chemo, radiation. Metastatic. What does metastatic mean? It moved, right? It might have started in the bone here, but then it kind of moved and traveled and started the cancer somewhere else. So just because a cancer starts somewhere doesn't mean it's just going to stay there. It might move somewhere else in their body. Okay, this is the last one, gout. Woo! What is gout?
Uric acid
Yeah.
buildup in the joints.
Yeah, that's what I heard. Uric acid. So you have crystals that are deposited in the joints, the connective tissue. A lot of times people will see it in their hands, their feet, but you might also feel it and see it in their hips, knees, anywhere where you have a joint. It's really painful. You have a lot of inflammation, so you might see a lot of swelling in those joints. Primary it's most common, and that's an inherited issue with purine metabolism. Where are purines? Like that's something we eat. Where do we find a lot of purines? We used to call this rich man's disease because a lot of meats and like rich foods. I think there's some cheeses and like things that usually cost more money. Like those are the ones that cause a lot of the inflammation. So they used to say, a long time ago, it was the kings and people in the court who would have this disease because the common people were like, well, we can't afford that. So they didn't have that issue. Signs and symptoms, your joints are hot, inflamed, and painful. A lot of times the great toe, your big toe is kind of one that usually will get inflamed and hurt a lot. And sometimes with chronic gout, you can actually get these deposits of they're called tophoid, these like stones under the skin with that uric acid it grows into. It can also cause renal stones. What's renal?
Kidneys.
Yeah, it can also cause kidney stones too. How do we diagnose it? Well, we're gonna look at their uric acid, right? Because if they can't metabolize this, it's gonna be a higher amount in their blood. So that's gonna be a pretty good indicator. And then sometimes they'll aspirate the joint fluid and test that for the uric acid as well. They're gonna usually have some medicines. Colchicine is one that helps to decrease the uric acid, and it helps with just like acute inflammation. So if they're having an exacerbation, it's just a really bad attack, they might take that, as well as NSAID, anti-inflammatories. They also might take some preventative medications too. These are more that just help to kind of decrease the overall symptoms to keep them from going into an attack. We're going to teach them about high foods and purines. Sometimes cherries and cherry juice, like an extract, can be helpful to these patients. It helps the inflammation. Want to avoid aspirin, diuretics, alcohol, and stress, and increase the fluids to help avoid kidney stones. Oh, guys, we made it. Okay, that felt like a long one. Let's take 10 minutes, and then we come back. We're going to work on the case study that we talked about. It'll be good. Actually, I really like these case studies.
I got it open. Right, again.
You decided to go.
Yeah. Just like.
All right, let's go ahead and find our seats. A couple of updates. Like I said earlier, I am very much a time optimist, so I'm not going to have time to cover the second part of musculoskeletal. So I'm going to go ahead. And just record a little mini lecture. If you want to watch it, you can. If you don't, that's fine. I'll post that later this week. But the second part of the musculoskeletal lecture had things like osteoarthritis, some of the joint surgeries. You can very well just read your book, but I'll also record a mini lecture that you guys can watch if that's helpful for you. We're going to enter and do another case study like was similar to what was part of your homework. I found one I liked a little bit better for us to do in class. So I want you to enter the case study, but don't start answering questions yet. We're going to do this together. So you can either look at this QR code here, or in the class announcements, I put the link for the case study for today. So I like introducing these to you guys because I'm not sure if you're aware, in 2020, they started, the NCSBN, or the people who are responsible for the NCLEX, so your national nursing exam, started doing things a little bit differently. When I took the NCLEX like over 20 years ago, it was strictly multiple choice. That's all the questions that I had. Oh gosh, I don't know, 5 years ago or so, they started putting other question types like multiple response or select all the reply. I know they're our favorite questions, aren't they? They're really hard. What they discovered was that there's a lot of people who we're not able to tell how well somebody's going to do at nursing, especially their critical thinking, strictly by multiple choice questions. So the NCSBN developed these new generation NCLEX test questions. So if you ever see NGN test questions, that means new generation NCLEX test questions. When you take your NCLEX, you're going to get a series of case studies. what I understand, so the NCLEX, it's gonna be a minimum of 85 questions and a maximum of 240, is that it? And it kind of works on a balance. At 85, they are 100% sure, like you have passed this. It shuts off, you're done. If it needs a little bit more time to get you to that passing score, you're gonna continue to take some questions. In that first 85 questions, you will get 3 case studies. After that, you might get other test questions that are the new generation ones, but we know, like NCSBN has told us, you guys will get 3 case studies. And so I want to start introducing you guys to the case studies because you're going to see them in the NCLEX, and they can be a little confusing if you haven't looked at them up until now. So the case studies always are a grouping of 6 questions based on one patient. And in that case study, they're going to add more information or ask you different questions about the information they already gave you. So it's important that we kind of understand how these questions work to prepare you for the NCLEX, and because it really helps you to develop critical thinking. So is anybody not in the case study yet? So in the announcements, click on the case study link, or you can scan this QR code. And we're going to go through this together. All right, if you're just coming in, go to announcements and click on the case study link for today. And we're going to go through this case study. So you should have a screen that looks like this. Don't worry if you can't get there. You can look on your partners, friends, neighbors. So in these 6 case study questions, they're all going to be a little bit different. The question types are a little bit different. We're just going to start exploring what those might be. So I think we're almost at least about there. So let's all click the arrow button and let's go to the first question. So this is really common to see for these NCLEX style case study questions, where it gives us kind of a header, which is the nurse caring for a 70-year-old female patient to a rehab unit following a right hip replacement 2 days ago. That's kind of the general scenario. Then it gives us nursing notes. I really want you to focus on these nursing notes to understand what they're saying. So this says day 1, 0800. All right, so we know this is today or right now, 0800. Client admitted last evening from hospital with indwelling urinary catheter in place, secondary to urinary retention. Upon entering room, client found attempting to get out of bed unassisted, saying, "I need to feed the cat." Client also grabbing at lower back, yelling, "It hurts." Lungs clear to auscultation, bowel sounds hypoactive, times 4 quadrants, indwelling catheter draining cloudy yellow urine. Then it gives us her vital signs. Temperature 100.1, which is also 37.8, pulse 96, respiration 16, blood pressure 122/68. So that's kind of our scenario. Our first question is that it says to drag the 4 findings that need immediate follow-up on the right. So who feels like they know one of the immediate findings? Go ahead. Pain, absolutely. I would agree with that. Another one? The urine, yeah, it's cloudy, right?
Confusion?
The confusion, I think that's for sure a third one. What about the 4th one? I would probably say the temperature. You know, bowel sounds being hypoactive. They're hyper.
Hypo.
Yeah, they're hypoactive. I don't really feel like that would be a priority finding because she had surgery not too long ago. She hasn't probably eaten too much.
Right.
It's in the middle of the night. Or no, it's 800. She probably hasn't eaten yet. I don't think I would say the bowel tones are a priority finding. I would say if I was going to answer this question, I would say definitely the urine being cloudy, the confusion. What did we say? Pain and temperature. Now, just so you guys know, this isn't prioritizing. This is not asking you to prioritize what is the most important. It's just saying out of this list of items, which are the top 4 that need to be seen. Okay. So good job. You guys are correct. It doesn't tell us that they're correct, but that's correct. So here's the thing I want you guys to notice. It gives us the exact same case study and nursing notes. if it helps you to read through, because see, it says day 1, 0800, there's nothing new. You don't have to reread that whole section. If that helps you to reread it, for sure, go back and look. But I wouldn't necessarily waste your time in a test going back and rereading it right then. I'm looking, I'm saying, okay, that's the same thing. Day 1, 0800, they're gonna identify if there's another day 2 or something like that. So I'm gonna go right down to the question, so I don't waste a bunch of time rereading that right then. All right, this says, which problem or problems could the client be experiencing? Select all that apply. So now, if we want to, we can go back and reread the nursing notes, or we can just choose. Anybody have an idea of what problems? You answer a lot. Let's go back here. I absolutely think a urinary tract infection is possible. Anything else going on?
Delirium.
Oh, here it is. I hear dementia and delirium a lot.
Delirium.
It's confusion, but it's not like progressive and urban.
Right, so delirium is acute, while dementia is chronic. So this is something that she didn't necessarily experience beforehand, but now with the infection, she is experiencing. So I think delirium is absolutely a possibility. Any other things we think that could be happening?
Renal calculi. You grabbed her back and said it hurts. That's where your kidneys are.
I hear you. Anybody think else she thinks she has renal calculi? Not usually. A urinary calculi would be like a kidney stone.
Yeah, but if it breaks up into little pieces, can't it be grainy and like on the feet?
It might have sediment, but it's usually not cloudy. If anything, you might have blood in the urine because it's causing that irritation around the kidney or the ureter. So I would say I really doubt it's renal calculi. Yeah.
What about constipation? Because it says bowel sounds are hyperactive.
Yes.
Wouldn't that make your stomach hurt?
Might make your stomach hurt. There's usually not confusion with constipation, or fever. So that makes me kind of think, could she be experiencing it? Possibly. Is that what's kind of, they're kind of trying to get to the root of what's causing this? What is happening that's what is the causative agents? Yeah.
Maybe one thing to think about the context, she might be constipated, but I mean, it's the problem, it's probably not, because it's expected. If she just had a surgery, she's probably on a bunch of opioids, she's probably constipated, it's expected, so it's not.
Right, it's
necessarily a
expected
problem.
versus a problem, yeah. Bree, was that what you were gonna say too?
No, I was just gonna say the infection.
The incisional infection, and I agree, like thinking about having a fever, some confusion, but do we have anything in the nursing note that points us towards the incision being infected?
No.
What points us towards an infection other than the fever and the confusion?
The yellow, redness, soreness.
Right, but in the nursing notes, we just have the cloudy urine, right? That's the only thing other than the fever that kind of helps us narrow down.
Right.
So I would say probably delirium and UTI, like those are the things that she might be experiencing. Which are the correct answers. Renal calculi, just for you guys who are thinking that, if you have a urinary tract infection, which that's what we're looking at, that can have pain that radiates to your lower back, like your kidney area.
So when I looked up the renal calculi symptoms,
Mhm.
on the penmedicine.org was the first one that popped up, and it says that urine smells bad or looks cloudy is a symptom. So why is it not?
If you had a UTI in association with it, I don't know that's why I don't really like the Google. I would stick more with your textbook or with, I just don't know that source. So let's put a pin in it and circle back. We can look at our textbook later about the renal calculi, but I don't want to get too far off track because I want to keep on this lady. So let's go to our next questions. Remember, there's 6 questions. Now we have our third. So now it didn't even give us our nurse's note. It just has this scenario and it says, what's the most appropriate word to complete the sentence? So the top priority to assess is
Urinary tract infection.
right, because if we think she's got UTI or delirium, could one of those be causing the other?
Yes.
The UTI, right? Infection can often cause delirium in older people. So that would be our priority assessment. So we're gonna go over and pull that over. And you can see if I try to pull another one, oh, it does let us. Ooh, okay, well, it really is only one. And I would look at this question too and say, it says the top priority. It doesn't say top priorities. It's not plural. So it really is just asking for one. All right. And the correct answer is UTI. All right, so here they give us also the nursing note again, but is there anything else beyond that 8 o'clock note we already read? There's not. So we don't have to go through and reread that all unless we need to reference it again. So now it says select the orders from each of the category that we might anticipate. So we as nurses are not ordering these, right? It's the providers that are going to order these, but we're going to anticipate that they're probably going to order some of these things. So there can be more than one in each category. So just looking at like our nursing orders, what do you think that the provider might order? Okay, let's go one at a time because I heard. So are we going to monitor INO?
Yes.
Yeah, anytime that we have something affecting our urine, we're going to always just kind of see what's going in, what's coming out. Does it kind of match up? Are we going to discontinue the catheter? Oh, I hear a lot of answers. Okay. So somebody pick no and tell me why.
Cause he just had to get surgery.
Go ahead. Right, so she had urinary retention, so we're worried she's not going to be able to pee. All right, then somebody give me a pro, why should we take it out and the why?
Increase this retention.
She already has it.
Right.
Mhm.
Okay, even more so, I mean, if this is, you know.
Yeah. So who thinks we should take it out? And who thinks we should not take it out? Oh, wow, okay. All right, so we'll not click that for now. Apply a vest restraint. Yeah, not indicated. Obtain a urine culture.
Yes.
Yeah, absolutely. We want to see what it's growing. All right, let's move to medications. Do you think they're going to order clindamycin? What is clindamycin?
Antibiotic.
It's an antibiotic, yeah. So it's really good to know, especially with antibiotics, which we're going to talk next week with infection, really getting familiar with some of those names. Anything that says myosin, that ending piece, that's an antibiotic. So yeah, they're going to order some sort of antibiotic for her. What about docusit sodium? Ooh, I heard Stephanie say yes. So why does she need a stool softener?
I mean, again, if we're assuming, because standard procedure for somebody post op on opioids, who has hypoactive bowel sounds, they're probably constipated, and even though that's not necessarily for the problem, they're probably gonna help with their discomfort and pain.
So for this type of question, it's really trying to say more about the provider now, what they're gonna be ordering. I see where you're coming from. She
So they probably
probably,
already had that, so that's not something new.
yeah, I think you're overthinking it a little bit.
Okay.
What about dinazepril?
No.
What is that?
Is that a diuretic? Let me look.
It's a heart medicine, right? Looking at her blood pressure, heart rate, are we needing to correct anything there?
No.
What about sertraline? Maybe. What is it for? A what? Antidepressant, it's a selective serotonin reuptake inhibitor. And so it helps with mood and depression. But is her confusion and anxiety coming from depression or maybe from the delirium, like the infection? So I doubt that. Okay, before we move on, I'm going to tell you guys, everybody who said not to discontinue the catheter are wrong. Anytime, so one of the big goals of catheters, like patients with catheters, the very first thing that you find out, let's say you have a patient with a catheter, is how soon can I take it out? Now this is a very big shift in thinking. When I was a nurse 20 years ago, anytime somebody had surgery, a little bit of retention, anything like, oh my gosh, put a catheter in them. What we found is that caused a lot of urinary tract infections. People who have a catheter are at a much higher risk of urinary tract infections. So if they have a urinary tract infection, for sure, we're gonna be pulling that catheter out. Even though they had retention, we're still gonna give her the option or the potential of trying to pee. A lot of people after surgery have urinary retention. That's a side effect of the opiates that they receive in surgery and after. And usually the day after surgery, they're able to void just fine. So anytime we have somebody with a catheter, we're gonna take that out. We might want to put it back in eventually, right? But we're going to give them that chance to void on their own. And if somebody has an active UTI, that catheter material can actually become colonized with that infection. So if it's some sort of whatever, it's some sort of bacteria that's growing, right? That might actually grow into that catheter material. And so even if she needs that catheter, we're going to take it out and replace it with a new one. I saw there were some hands. Still question?
So when one of the discussions
She had a hip surgery. Yeah. Yeah. No, good question. So any questions about catheters out? If you work in any kind of structured environment with catheters, you are going to have to justify why your patient has catheter. When I worked at bedside, like on the floor, like right now in like recovery, we don't have to do that because we just send them out to the floor. But if you're at bedside nursing and your patient has a catheter, your charge nurse is going to say, okay, why do they have the catheter? When can we take it out? What criteria? They have to meet specific criteria to keep that catheter in, because we know it puts that patient at such higher risk. So that's another one of those clues. Any NCLEX questions that are saying like, do we put it in or take it out? Unless we have very good reason to take it out or to leave it in, we're going to take it out. All right, let's move on. Next question. Okay. Oh, hey guys, look, we have more information. So now, in addition to day 1, 8 o'clock, we have day 1, 8:10, healthcare provider notified. Day 1, 8:30, urine specimen taken from port of indwelling catheter using aseptic technique and sent to lab for culture. All right, so they had the orders for the culture. Indwelling catheter removed. All right, so they ordered it to be removed. And first dose of clindamycin administered. Nice job, you guys. You identified all those orders. Then we have day 2, 800. Client awake and oriented ×3. Denies back pain, but continues to report mild incisional pain, 2 out of 10. Voided, so they peed. 520 mils of cloudy yellow urine. Temperature 99.4. Pulse 80, respirations 14, blood pressure 118/70. Underneath that, it says these are the orders. So this is what they already received. The culture, discontinuing the catheter, monitoring INO, and the clindamycin. So nice job, you guys. You identified those orders, most of us, some of us. And now it's saying, hey, the client's cognition improved the next day after starting antibiotics. What should the nurse teach the client about the treatment plan? Select all that apply. So this is different. We want to make sure we know, like I said earlier, are we saying what are the things that are appropriate or not appropriate?
Appropriate.
Appropriate. We want to say, what do we need to make sure we teach them? So the entire course of clindamycin should be taken even if symptoms resolve.
Yes.
Yeah, we always want them to take all of those. Further evaluation to rule out dementia will be needed. No, her confusion's already cleared, so she doesn't need any of that. Removing the catheter will help restore body's normal flushing out of bacteria. Yeah, right. We took out that catheter, so now she can fully empty. Sometimes people with catheters in, they're not going to fully be able to empty the bladder because of how positioning and things are, where that tube's opening into the bladder. And sometimes you can have some residual urine even in there. And so if you have a UTI, it can just grow even more. Urinary output will be closely monitored for the first 8 hours after catheter removal.
Yes.
Yeah, because anytime we take a catheter out, we're giving that patient a chance to void, right? We're saying, no, we want you to do this naturally. But if they hit an 8-hour mark and they still haven't peed, we're going to be doing all the things we can to get them to pee. You know, I like to turn on the water and the faucet, dip their hand in a little water, think about running streams, whatever. If that doesn't work, usually I'll do a bladder scan and see, you know, is their bladder full? Usually it is. And if so, we might have to either put the catheter back in or do a straight cath, right? We want to empty that bladder. because we know, especially after having a UTI, if that urine is just sitting in that bladder, it's going to cause more infection and more issues with that retention. All right. If the urge to urinate is felt, try to hold off voiding to fill the bladder. No, we really want people to empty that bladder. If minimizing activity helps allow the body to fight infection. No, we want them to be up and active. The likelihood of developing a UTI in the future is decreased. Yeah, it's actually increased. The culture and sensitivity will identify the correct antibiotic to be prescribed for the infection.
Yes.
Yeah. Increase fluid intake up to 3 liters per day if possible.
Sure.
Yeah, usually we tell people try to drink about 2 liters a day, but when they have infection, we're trying to flush things out. Usually we'll say about 3 liters a day. So that's appropriate.
One question.
Yeah, go ahead.
Why is the likelihood of developing a UTI, decrease? Why isn't it not the right answer? So just
Oh.
figure out the catheter out. So
Right,
now-
but because you have infection in your bladder, it's always possible, like if you've already had a urine infection, it's possible you might get it again, right? We might not have cleared all of the bacteria with the antibiotics, even if they took it appropriately, there could be some that are left over. It just, anytime you have it, you're at higher risk of getting it again. Yeah.
So some, there's a culture and sensitivity.
Mhm.
So there's no more infection specimen. So how on the influx would we know to select, how would we know to select that? Now, I understand what the CNS is, but according to this particular case, it doesn't appear to, why would we run another one?
It's not saying to do another culture and sensitivity. It's just saying in general, the patient should know that when we get the culture and sensitivity of the urine, it directs us to give them the right antibiotic.
Okay, so it's just, okay.
It's not saying to do another test.
Okay.
It's just informing the patient of how that works. All right, so those are all the correct answers. Good job. Let's go to the next one. Okay, last question. All right, so do we have any more information up here? No, it's no additional information, so you don't need to waste your time reading that whole piece. So now let's go and decide, click to specify which statement indicates understanding or no understanding of the teaching provided. So we really have to look to say, are we trying to say, like, is this right? Is it wrong? What are they asking me? This is saying, based on the statement, did the patient understand or did they not understand? All right, so the patient says, I can stop taking the clindamycin all at once my symptoms are gone. No, because what is clindamycin?
Antibiotic.
It's an antibiotic. How long should they take it? Till it's all gone. Yeah, so that is not understanding. I will try to increase the amount of water I drink.
Yes.
Yeah, we do. I will buy cotton underwear from now on.
Yes.
Yeah, that's actually one of the things. Patients who have urinary tract infections, especially women, we want them to have cotton underwear because it's absorbent. It helps to keep them dry. That will help to prevent infection. I will try to hold my urine when I feel the urge to void. No, we want them to pee. I will take showers instead of baths.
Yes.
Yeah, we do. Baths can put you at higher risk of developing urinary tract infections. I can continue to use baby powder in my perineal area.
No.
Wasn't that also understanding?
Oh, yep, so, thank you, keep me straight. I can continue to use baby powder in my perineal area. No, it's actually not indicated. And sunburning when I void is normal. No, they should not. Oh, nope, thanks, guys. These are hard. All right, and then that is the end. And the frustrating things about these is that it gives you a download of your response, but it doesn't actually tell you the correct answers.
That seems way better.
Yeah.
Yeah.
That was way more appropriate than the one you gave us.
I know, the one you gave us.
The one I gave you, I thought was kind of fun, but it was hard because we haven't gone through renal, which is why I decided to change it up for in class. But I still think exposure to these case studies and how they were is still gonna be helpful.
Yes.
Okay, do you guys want to do KWL or go through the case study that we did for homework?
Case
study.
Okay, let's go quickly. We're gonna fly through the case study. Do.
What the hell happened here?
What was it? Okay, let me go a different way. All right, if you want to go and open up the case study again, you can, otherwise follow with me. All right, so here we go. It tells you question 1 of 6, 35-year-old female patient on renal disease on peritoneal dialysis. That's a little bit complicated. Peritoneal dialysis is where you have a catheter inserted into your abdomen. Your peritoneal area is the potential space between your internal organs and your stomach wall. So that catheter goes right in between there, and they fill it up with this solution that then leaches out some of that stuff that we need to get rid of, that your kidneys aren't working, and then they drain it back out. Kind of like a lavage. It's more like like osmosis, right? Higher concentration to lower concentration. So it's a lot of lower concentration, and it's going to pull things like potassium, extra creatinine, all that stuff out of your system into that fluid. And then they drain it out. Also, it pulls extra fluid out, and then they put it back in, or a different one back in. All right. Client was started on automated dialysis 6 months ago. She developed fever, vomiting, abdominal pain 1 day ago. Current assessment, temperatures 39.1, heart rate 104, respiration 16, blood pressure 145/87. Her current weight is 147 pounds. NKDA, what does that mean?
No known drug.
No known drug allergies. Periumbilical tenderness. Where's periumbilical?
Right next to your belly button.
Yeah. So peri is around, umbilical is your belly button. So tender around the belly button. Defense and rebound. So defense means when I go to do this, ooh, she kind of like doesn't even want me to touch her. And then rebound means I push in, and then she's like, oh, when you let go, that really hurts. That's what those things mean.
When you let go, it hurts.
Yeah, for the rebound. Erythema, what is that?
What?
Erythema, redness. It's just a redness. Erythema, where'd I go?
And creamy yellow.
And creamy yellow exudates. That sounds
Fuzzy.
disgusting. Around the peritoneal dialysis catheter exit site. Dialysate effluent. So that's that fluid that we put in and out. It's called the dialysate effluent. Yeah, this one was kind of tough. I'm sorry, guys.
Yeah, you.
All right, I'm gonna note not to do this for your first one before you've had renal. Well, let's do this again after we've had renal, and you guys are gonna be like, I know all of this. All right. I mean, the nice thing is this whole assignment was pass fail. You just had to do it to get credit for it.
Right.
All right. So the fluid is cloudy yellow, and the culture was obtained and labs are sent. So here's our labs. I'm not even gonna look all over them right now because I want to see what the question is about. So that's another trick for you. You don't have to look over all of it right away. What is the question actually asking you? Then you can go back and look, okay? So it says, what 5 findings are the most concerning? So it says temperature, 102.4.
Yeah.
I mean, that's pretty high. I'm probably gonna say, unless something else is crazy, I'm just gonna go ahead and click that because that seems pretty concerning. Heart rate 104.
Not really.
Yeah, I mean, that's a little bit higher than normal, but I wouldn't be like jumping out to go see them right away. Let's see what everything else says.
Right.
Respiratory rates,
No.
16, that's normal. Blood pressure,
Yes, a little bit. It's a little elevated.
it's a
but
little
not
elevated,
concerning.
but like I said, I wouldn't be like really concerned about that. Periumbilical tenderness.
Yes.
I'd probably be concerned about that, especially when they said that she's got the defense, like she doesn't even want me coming near her to touch it. That's pretty severe, right? The dialysis catheter exit sites.
Yes.
Yeah, that creamy yellow exudate. Ugh. All right, and then the last 4 are her labs. So they're saying the BUN, creatinine, serum white blood cell and dialysis white blood cell.
I have a question before we even go any further.
Yeah,
The Avogadro's number right there, the serum white blood cells, how would, like, I was trying to figure out how to find out if that's normal or not. Serum white blood cells on the bottom, it's like 10,
wait, where are you at?
Right
Oh,
there.
serum.
what, like it says times 109 cells per liter. I was like, what? It pissed me off last night. I'm not even gonna-
I see. So when they're asked, because that's the nice thing, when I took the NCLEX, they did not give me reference ranges. I had to memorize all of the reference ranges. You guys still need to kind of know if something's high or low or what that, you know, what it means, but they're gonna give you the exact reference ranges. That's really nice.
Yeah.
So when you look at serum white blood cell count, when you're looking at something like this, look at the normal, 4.5 to 10.5.
Times.
Ignore that point. 4.5 to 10.5. Over here, it's 14.222. Like that's what you're comparing.
Okay,
The normal would be the 4.5 to 10.5. You're comparing it to this person has 14.22.
right.
I agree, this is a little bit confusing. Most facilities or most lab sheets aren't gonna have it listed in that way. But I probably read right over that because I'm really used to knowing white counts and like knowing that 14 is elevated, right? And you're gonna get there too. You're gonna be able to look at something and go, oh yeah, that's not good. So are we concerned about that white blood cell count?
Yes.
Yeah, that's pretty elevated. I would be concerned.
And what about the bun?
Yeah, so the BUN, so
The
46.
bun.
You can say bun. I've always just said BUN. It's either, I don't think either way is wrong. So usually we look at BUN and creatinine together. What does BUN stand for?
Yeah,
Yeah, blood urea nitrogen or nitrates, nitrogen, one of those. And we also look at the creatinine as well. So with these two, is there one that I'm more concerned with? Or that we are more concerned with?
the creatinine is really high.
I would actually say the creatinine. Usually, I used to work on a dialysis or like a kidney failure unit. And every morning we get the labs in and we try to like guess who would be the winners for that day of like, oh, they're for sure getting dialysis first.
But because she's a dialysis patient, you wouldn't really look at these though, right? Because
You for sure would, because that 10 means that so she has peritoneal dialysis.
but based off the question, it says only 5 nursing training, so.
Right, so what I'm saying is that peritoneal dialysis, that's what's pulling that creatinine, the extra, the things that don't work with their kidneys,
Out.
that's what's trying to be the kidney. So that means it's not actually effective. So she's got a really high creatinine because that peritoneal dialysis is not super effective right now. Yeah, well, she does have end-stage renal failure. Yeah, that's why she's on the dialysis.
The creatinine would be the last choice.
Honestly, you could make a case for either the creatinine or the dialysate.
So what's few mean? Like that was confusing to me too. I'm like, what's few? 2, 3, 7?
Few means like a handful. Anything more than a few will be on here. 63% is a lot.
So Rebecca, I had 2 CRT technicians look at this case study with me.
Yeah.
And they had a really hard time with this case study.
They're hard.
They were like, what the hell?
Yeah.
And as they're running this machine with the patient like 5 feet from us. And they're like, yeah, I don't know.
They're hard questions, but that's why I'm having you guys look at them now, especially because it helps you like look through and go, oh my gosh.
Like
Okay,
that.
so I'm looking at the answer sheet to make sure I tell you guys correct. So temperature is 1,
Mm-hmm,
periumbilical tenderness,
mm-hmm,
dialysis catheter site, serum white blood cell, and dialysis white blood cell.
So not the bun.
So it
or
wouldn't be the BUN or creatinine.
Boom.
So there you go. Yeah.
You're welcome. Because she has them.
She does have end-stage renal failure. Yeah.
So if she didn't have the end-stage renal failure, that's when we would look at that and be like, oh, something's wrong.
Yeah.
Okay.
Yes. Yeah. All right. So then moving through here, it doesn't say anything else new. It gives us the same labs.
We'll throw you a parade later, right?
All right, if you have to leave, please just fill out your KWL and turn it in. I realize it's 10 o'clock. We'll fly through this. Is the BUN high, is that from peritonitis or is that from end stage renal?
End stage.
Yeah. What about the creatinine?
End stage.
What about the C-reactive protein? We look at that. That's it. It's an inflammatory marker. So it tells us that there's inflammation going on somewhere. So that would be with infection. What about the potassium?
Yeah. Great stage.
End stage.
Phosphorus?
Good stage.
Hemoglobin?
Both? 32 now.
Peritonitis? It's actually from end stage. When somebody has kidney failure, they don't produce. what the-
Iron, right?
What's that?
They can't process it because of erythropoietin.
Exactly. They don't produce erythropoietin, which helps to stimulate red blood cell growth. Good job. And so people in end-stage renal failure will typically have low hemoglobin and hematocrit. White count, that's the peritonitis. Neutrophils, peritonitis. Yeah, that's a type of white blood cell.
So was there any, because it says you could have more than one answer?
Yeah.
for- Like, was there any that would have been both?
Oh man, I didn't read that question well enough. Let me look to see.
It says you could have more
You
than-
can have both.
It does. No, there were not any.
Okay.
There was. okay.
No, they'll look through my answer sheet. These are tough ones. Okay, on here. Okay, it gives us no new information and it says the client's diagnosed with peritonitis. Good job. Drag the most appropriate word choice to fill in the blank. So the
Sepsis.
client is at high risk for developing
Sepsis.
sepsis. I would agree.
I was looking,
You're correct. We are correct.
it said, I was
Oh, it's
reading
just that
somewhere
one?
else, I think in
Sepsis.
Google University. I was in Google University last night and it said something about cellulitis and I was like, that didn't sound like that's
You
associated
can
with.
develop abdominal cellulitis from peritoneal dialysis, but with this patient, I would say it's far more likely that she would have sepsis related to the
Right.
infection. Okay, so there's lab information back. The dialysate effluent grew gram-negative rods. All right. So are we gonna say these interventions, are they appropriate or not appropriate? So daily weights?
Appropriate.
Appropriate. Anytime somebody has renal failure, we always want to weigh them. Blood culture stat. Yeah, it's a pretty good idea. Peritoneal dialysis care Q shift.
Appropriate.
Yeah. IV fluids, D5 1/2 NS with 20 mil equivalents of potassium at 120 an hour.
No.
Why would we not want to do this?
Their potassium already.
Yeah, so first we can look up here and see her potassium is already elevated. So we don't want to add any more potassium. And then once we talk about renal or kidney failure more, we're going to talk more about how these patients don't actually die out. They don't get rid of their extra fluid very well, right? Like that's what our kidneys do. So it's very rare that we'd ever put renal patients on IV fluids, especially at 120 an hour. That's going to be overloading their system. Calcium carbonate with meals. Oh, what was their
No.
calcium? It was a little bit, I mean, it's normal, but actually we usually do give them calcium.
Yes.
Yes, we do want Vanco, the IV antibiotic, gentamicin intraperitoneal daily.
Yes.
Yeah, probably. Let me just make sure. Oh, actually, you know what
No
they're
Vanco?
saying? They're saying a gentamicin, no Vanco.
Yeah, no Vanco.
Yep, because they're saying treat it localized first. If it gets back that the infection is
got
in the
that right.
blood with the blood culture.
Everything else. is
What
wrong,
about
Bobby.
enoxaparin subcutaneous?
Yeah.
Actually, it's
No.
not.
Really?
It's a blood thinner and we
Yeah.
don't have any information that says that we should. What about Epotin alpha injections? Yeah, what is the Epotin alpha?
I looked this up last night, now I can't even remember.
It helps to stimulate red blood cell growth. Yeah, so since people with renal failure, they're not producing red blood cells as often, we usually will have them give those.
63, yeah.
Okay, so now we want to say we have a nurse, an LPN, and a UAP, a nursing assistant, CNA. Which should be
I have a
what?
question. So I'm reading this little book, right?
Is it about the other question? We'll come back to that, 'cause I wanna
Yes,
respect everybody's time.
Okay.
All right, vital signs. Who is appropriate or the most appropriate to the vital signs?
UAP.
Probably the UAP. Everybody is available to, but that can be delegated to the UAP. Dialysis exchange. Usually it's the RN, yeah. Daily weights, UAP. Peritoneal dialysis catheter care, Q shift. The LPN can do that. Intraperitoneal dialysis or gentamicin.
The LP. RN.
That's the RN, yeah. The RNs are usually the ones that are actually doing the exchange, any medications that go in there. Peritoneal dialysis catheter care teaching. It's actually the RN for that one. All right, good job, you guys. Okay, last question. No new information. They teach them, and now we need to say, does this patient understand or not understand self-care about the peritoneal dialysis? It says, before cleaning the area, I'm gonna wash my hands with soap and water and put on clean gloves.
Yes.
I think it understands, but I don't know. Usually at home, we don't tell patients to put gloves on.
Yeah, they just wash their hands.
But it says understand, so yes. I should remove crust or scabs at the exit site before washing the site. No. I should hold the catheter in place during cleaning to prevent injury to the skin.
Yes.
I should scrub the exit site vigorously with an antiseptic solution like iodine or chlorhexidine. No, we don't want to scrub vigorously. We don't want to use chlorhexidine or iodine. They're a little bit abrasive for every day. I'll put antibiotic cream around the skin, around the catheter with a cotton tipped swab every time I change the dressing.
Yes. Yes.
Yeah. I will not use any creams with petroleum because they can damage the catheter.
Yes.
Yes.
Yes, you understand.
Yes, that's correct. Okay, sorry. Thank you. I'll leave the exit site open to air or covered by loose clothing.
Yes.
And
No.
oh, did I click the wrong button? Oh, it's too late.
Take it over. Take it over.
Okay, that one was a bit tough, so I'm sorry if that stressed you guys out. Please know it was pass or fail. By doing the assignment and turning it in, you got full points.
Yay.
We're gonna have more of these as you
No.
progress through the program. I like to put them in the course because I think they really help you to think through. And just remember, you're gonna have 3 of these case studies. Those 6 question blocks, you will have 3 of those when you take your NCLEX.
So I think always.
For this class, they will always be pass fail. I mean, I can't say because some of the other faculty use them, so I don't want to speak for how they use them. I just like to use them as pass fail. All right, I'm gonna go ahead and review the test. So if you want to stay around to review the test, you are welcome to. I just ask that you do not record or take pictures because we want to protect the integrity of our test. Let me just get there. Yeah, do you guys want to bring your food back here? Yeah, if you want to take 10 minutes and then get food, you can come back. That's fine with me. Yeah.
Okay.
Oh.
Bit of fasting.
Oh, that's okay.
That's,
That's okay.
that's
It's fine. It's fine.
that's it very well. So do you think that the phone can be useful like jumping
I've never seen that. I've seen like their skin grafting information, but I've
yeah,
never.
or maybe I'm not done that. I can get it from this person.
Yeah.
I was just wondering, it's just one of the things that I would like to know if you can find that.
You know,
Because I thought like it's a tissue or maybe, I don't know if it's
Yeah,
a tissue.
I don't think they actually have like bone transplant, like your bone breaks, they can give you mine. But I do know in surgery, like when somebody has I'm thinking like in the knees or like there's pieces, they do like a dabber piece. So it's not the whole bone, but I think there's pieces of it they can do. So interesting question though. Yeah.
I was just like, when they say what a diagnosis, they think about that.
Good question.
Yeah.
Yeah, yeah, you're doing good. Thank you, John.